So, respected chairpersons, myself, Dr. Anjani Kumar Pathak, Assistant Professor in Periodontology, that is a branch of dentistry in King George's Medical University, Lucknow. And the topic of my presentation is association between diabetes mellitus and periodontal status in North Indian adults. Okay.
Pointer?
Yeah, no. So, what the diabetes mellitus is not my topic. A lot of discussion has been made. but it is, in my point of view, it is a complex metabolic disorders characterized by chronic hyperglycemia. That's very simple definition and definition by a dentist. And it can be of type 1 diabetes mellitus, type 2 gestational diabetes. And this data is obtained from WHO. Diabetes is an important public health problem affecting 245 million people worldwide, and each year 7 million individuals develop diabetes, and the projections for the year 2030 expects that 366 million people will have the diabetes worldwide. Now, it is a bidirectional relationship between diabetes and the periodontitis. Let me explain what the periodontium is. Periodontium is a structure that surrounds and supports the tooth. It contains gingiva, that what we call the gums, periodontal ligament, cementum, and alveolar bone. Any part of this is inflamed is called as a periodontitis, and it is a bidirectional relationship. So, evidence for support. Diabetes has been confirmed as a major risk factor for periodontitis, and the risk of periodontitis is increased by approximately 3-fold in diabetic individuals compared with the non-diabetic individuals. And according to the US National Health and Nutritional Examination Survey, the adults with HbA1c level of greater than 9% had a significantly higher prevalence of severe periodontitis than those without diabetes. So, in early 1990s, periodontitis was sometimes referred to as a 6th complication of diabetes, and in 2003, the ADA acknowledged that the periodontal diseases is often found in people with diabetes. So, these are the various complications, need not to be discussed here. Commonly, there are 6th complication: retinopathy, nephropathy, neuropathy, macrovascular disease, altered wound healing, and the 6th one is the periodontitis. So, what are the other complications of diabetes, manifestations of diabetes? Like xerostomia, greater susceptibility of oral tissues to trauma, more opportunistic infections like Candida albicans, greater accumulation of plaque, greater risk of caries, delayed wound healing, and greater susceptibility to periodontal disease, and oral paresthesia, including burning mouth or tongue, altered taste sensation, enlarged velvety red gingival tissues that bleeds easily, multiple periodontal abscesses, mobile teeth indicating bone loss, proliferative tissues at the gingival margin, inflammation spreading through the attached gingiva, and lack of resolution of gingival signs after conventional treatment, severe aggressive periodontitis, and delayed wound healing. Now, this is a classical picture of periodontitis in diabetic individuals. Periodontally disease sites in diabetic patients harbor similar microorganisms as compared to the non-diabetic individuals. So, it suggests that the increased prevalence and severity of periodontitis in diabetes may be due to difference in host response factors. Now, effect of diabetes on cellular response. The defects in inflammatory cells like PMNs, monocytes, and macrophages, there is an altered adherence, defective chemotaxis, defective phagocytosis have been observed in some individuals with diabetes. And these defects affecting this first line of defense against subgingival microbial agents may result in significantly increased tissue destruction. And many of these PMN abnormalities can be corrected with improved glycemic control. Now, Oliver and colleagues have been suggested that hyper-responsiveness of or increased number of PMNs within the gingival crevice. Gingival crevice is a space that exists between the gums and the tooth surface. It is a very narrow space. poorly controlled diabetic patients as indicated by elevated levels of PMN-derived enzyme beta-glucuronidase. And the monocyte macrophage cell line is the critical to cell-mediated host defense in periodontal disease. And many studies suggested that many diabetic patients possess a hyper-responsive monocytes macrophages phenotype in which stimulation by bacterial antigens such as lipopolysaccharide results in dramatically increased pro-inflammatory cytokine production. Now, one of the most important effects of diabetes on collagen metabolism, it is the primary constituent of gingival connective tissue and the organic matrix of the alveolar bone. And change in the collagen metabolism contributes to alteration in wound healing and to periodontal disease initiation and progression. Matrix metalloproteinases like collagenase are produced by all the major cell types in the periodontium when activated by various cytokine and growth factors including polymorphonuclear cells, fibroblasts, macrophages, endothelial cells, osteoblasts and osteoclasts. Now this is the collagen effect on of diabetes on collagen metabolism. In hyperglycemic stage there is a reduced synthesis of collagen and glycosaminoglycans, reduced collagen maturation, collagen homeostasis is affected, and GCF. GCF is a fluid present within the gingival crevice. This is called gingival crevicular fluid. So its activity, collagenase activity is increased in the GCF. Now in case of diabetes there is a cross-linking of collagen, and because of this cross-linking of collagen turnover rate is solubility of collagen is decreased, and because of this solubility decreased collagen solubility, the turnover of collagen is hampered, and there is an accumulation of matured collagen and is in the connective tissue, and there is a defective formation of newer collagen in connective tissue. So there is a defective wound healing in case of the diabetic individuals in periodontium. Increased blood glucose level in diabetes are reflected in increased levels of GCF and glucose, and many in vitro studies show decreased chemotaxis of periodontal ligament fibroblast to PDGF, that is platelet derived growth factor, when placed in hyperglycemic environment compared with the normoglycemic condition. And studies have also shown that decreased production of growth factors like PDGF, FGF and transformic growth factor beta, and thus adversely affect events and local host response to microbial challenge. This is the overall effect. The wound healing is affected as a cumulative effect of there is an altered cellular activity, decreased collagen synthesis, glycosylation of existing collagen that will result into the reduced collagen solubility, delayed remodeling of wound site, and increased collagenase activity. Thus overall effect is defective wound healing. Now there is another important factor that is AGE, advanced glycation end products. Schmidt and colleagues demonstrated a twofold increase in AGE accumulation in diabetic gingiva compared with the gingiva with non-diabetic subjects. And the formation of AGE stimulates arterial smooth muscle proliferation, increasing thickening of the vessel walls. And there is a formation of, in case of diabetic individuals, there is a non-enzymatic glycosylation of proteins occur that will result into the accumulation AGE formation. That AGE will cross-link the collagen. Now, overall effect of the AGE, it plays a central role in diabetic complications, alter function of extracellular matrix, affects collagen stability and vascular integrity, and increased cross-linking between collagen molecules, reduced its solubility and decreased turnover rate. This is the effect of AGEs. Now, how AGE is affecting the vasculature? There is an increase in thickness of gingival capillary endothelial cell basement membrane and the walls of small blood vessel. And that's when there is a narrowing of lumen, impaired oxygen diffusion and nutrient provision across basement membrane and altering normal periodontal tissue homeostasis. And enhanced cross-linking of AGE modified collagen in the basement membrane inhibits normal degradation of these proteins, increasing the thickness of basement membrane. And elevated LDL levels, especially it is common in type 2 diabetes, And the AGE modified arterial collagen in gingiva can bind circulating LDL, causing atheroma formation and further narrowing of the vessel lumen. All these events may play a role in altering the tissue response to the periodontopathic bacteria, resulting in increased severity and progression of periodontitis. Now, AGE is also affecting the inflammatory response because accumulation of AGE stimulates the influx of monocytes. AGE interacts with the receptor RAGE on monocyte cell surface. This halts the migration of monocytes, fixing them at the local site. This induces a change in monocyte phenotype, upregulating the cell and significantly increasing pro-inflammatory cytokine production and causing decreased GCA production of TNF-alpha, PGE2 and interleukin-1 beta. This is the AGE production. Periodontopathic bacteria will causes the inflammation and that enhances the periodontal tissue breakdown. In the same way, AGE will bind with the RAGE that will impair the repair, and again it will add on the periodontal tissue breakdown. Now, AGE has also a role in the oxidative stress. AGE formation results in the production of reactive oxygen species and enhances oxidative stress and the subsequent endothelial cell changes that occur to contribute the vascular injury implicated in many diabetic complications. And what about the osteoblastic function? AGEs have detrimental effects on the bone metabolism, that is osteoblastic cell proliferation, leading to impaired repair and bone formation and decreased extracellular matrix production, reduced bone formation and diminished mechanical properties of newly formed bone. So let us discuss the other side of the coin. That is effect of periodontal infection on the glycemic control of diabetes. Acute infections have been reported to alter the endocrinologic metabolic status of the host, thus leading to difficulty in the controlling blood sugar. Bacterial infections decrease insulin-mediated glucose uptake by skeletal muscle and produce whole body insulin resistant. Acute endotoxemia and cytokine production, mostly TNF-alpha and interleukin-1 beta, induce insulin resistance and decreased insulin action. So this is how periodontitis affecting the diabetes. First, the periodontal disease, that is a host microbial interaction, then pro-inflammatory cytokine production, which will result into the inhibition of tyrosine phosphorylation of insulin receptors, reduced glucose uptake by cells, then increased insulin resistance, and this worsened glycemic control. So it is a double trouble. This is overall picture how the diabetes and periodontitis is related with each other. So periodontal treatment is associated with improved glycemic control. Now, periodontal infections are most commonly gram-negative infection, which will result into the increased insulin resistance and worsened glycemic control. If we perform a periodontal treatment, that will improve the insulin sensitivity and thus improve the glycemic control. Most recently, the Cochrane collaboration has reported on studies that investigated the relationship between periodontal treatment and glycemic control in people with diabetes. 3 studies were included in this meta-analysis, which reported a significant reduction in HbA1c 3 to 4 months after the conventional periodontal therapy. This is the study. Now, our study, this is association between diabetes, mellitus and periodontal status in North Indian adults, published in the European Journal of General Dentistry. The rationale of this study is that periodontitis is considered as one of the main oral health problems encountered in the patients with the diabetes. With the increase in the incidence of diabetes worldwide, its negative impact on the oral health should be considered. The objective of aims and objective of this study is to investigate the prevalence of periodontal disease among individuals with type 1 and type 2 diabetes in North India and evaluate the association of this condition with behavior like smoking and other clinical variables. The methodology: 300 dentulous male and female individuals over the age of 30 years were included. Type 1 and type 2 diabetes were determined in individuals with a previous history of medical diagnosis, and there is a self-administered questionnaire included demographic and smoking status information. So medical examination: the HbA1c test is being done. And the dental examination, it is a probing method, that is CPI, Community Periodontal Index, was used for periodontal assessment. And gingivitis, that is the inflammation of the only gingiva, and when this inflammation exceeds to the bone, then it is called as a periodontitis. The oral hygiene condition was visually evaluated by examining all teeth present without using any disclosing solution, and can be classified as a good, fair, and poor. This is the statistical analysis and the results. The average age of the study population was 55.3 years. Average duration of diabetes was 5.1 years. The sample comprised mostly of women. 15.3% of the patients were tobacco smokers. 28.7% had type 1 diabetes, and 71.3% had type 2 diabetes. A total 6.7% exhibited a healthy periodontium. 68% exhibited gingivitis, 25.3% exhibited periodontitis. The univariate analysis revealed that periodontitis was significantly more prevalent among men, among participants with type 2 diabetes, those with more than 5 years of diabetes, those with tobacco smoking habits, and those who had not visited the dentist in the previous year. Come on to the discussion. It is the second largest health problem, and the advanced periodontal disease affects 10 to 15% of the population worldwide, and is most common oral infection in India, with a prevalence rate of 66% among individuals of age 15 years and about 89% among adults in the age group of 35 to 44 years. And the diabetic individuals suffer more from periodontitis. In the present study, there was a 25.3% prevalence of periodontitis among individuals with diabetes. This demonstrates that the diabetic individuals have a higher prevalence of periodontal disease than individuals without diabetes. And it is a mounting evidence in the relationship between oral and systemic health will confront dentists, physicians, and other healthcare workers with the importance of working together and for the early diagnosis of diabetes and co-management of oral and overall health. And periodontitis is more prevalent in diabetic men. In the present study, there was a statistically significant association between periodontitis and gender. This corroborates that other studies reporting that periodontal problems are more prevalent and more severe among diabetic men. And such a finding implies that public healthcare services need to actively seek changes in clinical hours and other measures that address care for men with diabetes. And no significant duration of diabetes. There was no statistically significant association between the time from which the patient was diagnosed with the diabetes and the presence of periodontitis, and literature also contains controversial evidence on the relationship between the duration of diabetes and periodontal parameters. And according to the WHO 2007, tobacco smoking is a risk factor for the development of the periodontal disease, and in the present study, tobacco smoking was associated with periodontitis. It has also been reported that individuals with diabetes who smoke are 1.71 times more likely to exhibit periodontal disease than those who do not smoke. And the people with no visit to the dentist in the last year suffer more from periodontitis. In this present study, there was a statistically significant association between periodontitis and those who had not visited to the dentist in the previous year. Now, just to conclude, the result of the present study indicate a high prevalence of gingivitis and periodontitis among individuals with diabetes who utilize public health services in North India, and multiple determinants such as clinical and behavioral factors are associated with the prevalence of periodontitis, and public health care strategies are needed in order to broaden the access of oral health care services in India and to integrate healthcare professionals regarding care for diabetes. Thanks for patient listening.
Thank you, Dr. Pathak. It was a wonderful talk. I felt probably I am going through a session of diabetes, not as I was apprehensive, could be a session of dental sciences, but it was very, very informative, well received presentation. Now, the session is open for questions.
We have one question right here.
Hi, very interesting. I would like to know, is there any data in the literature or in your data involving periodontitis with complication of diabetes like retinopathy, like nephropathy, like neuropathy? Any association?
Number of literatures are present, ma'am. I would like to send you. I can.
But there is?
Yeah, a number of data, ma'am.
Not only with, just with small vessel disease. That's what I was looking for.
No, ma'am, periodontitis itself is regarded. Nowadays, it is in literature. It is well established complication of diabetes mellitus.
No, but I mean, if you have, if there is more periodontitis in diabetic patients who have neuropathy or nephropathy or
No.
Her question is whether periodontitis has anything to do with other chronic infections, like your cardiovascular complication, neuropathy.
Yes, my work is, I'm working on the cardiovascular disease also. And periodontitis is another complication for preterm low birth weight, preterm labor, but it has also already been established. But on cardiac patients, I'm working on that.
Yeah.
I'm working on that.
No, her question is also, I mean, much more than what you have perceived. She wants to ask, is there any association with other chronic complications like nephropathy and neuropathy?
No, it's still yet to discuss.
Not to your
No,
information.
not yet.
Fine.
And a question that always comes from the patient, because I'm working with children, what is the level of hemoglobin A1C optimal to do some tooth care? Should I send the child to whatever?
Etc.
What is the best hemoglobin A, or under what should we send the child to?
Ma'am, we perform periodontal surgery at the hemoglobin level of 9 even.
9 even.
9,
okay.
yeah. We can
So there is no problem.
No problem at all.
Okay.
Does it not affect healing process? Suppose you have tooth extraction.
We perform a very minor incision. So
No, suppose you undertake a tooth extraction of a child and hemoglobin A1 is more than 10%, say for example. Shall it not affect healing?
usually in India we don't perform a hemoglobin test prior to extraction.
But I think since you are leading during the dental college, as far as diabetes is concerned, you should start it.
But definitely, yeah, definitely.
What's the harm? You can control diabetes within 24-36 hours by starting insulin, etc. So I think you can take care of this.
No, we usually used to refer the.
I think this conference should be complimented for evolving one more issue, that he will take care of A1C in future.
Definitely, sir.
No, it's very common question. Yeah. No,
Acha, one more question from my side. What was the modus operandi to get diabetes patient for this study? Or it was a random search?
We recruited from the Department of Medicine.
Who was your, collaborator from medicine department?
My colleagues are senior residents. At that time, I was senior resident.
You were resident.
Senior resident.
No senior faculty had
No,
joined
no
there.
senior. No
Kesar
senior
Osman, etc. No.
No, sir.
Fine.